sure you have some questions. It's interesting when you read something. I did not remember that story from your first talk. I remember the story of the woman with the facial range who put on a brave face.
Yes, yes.
So, questions. There is plenty of opportunity, and I'm sure that I would welcome who'd like to ask.
All comments.
Not all comments, yeah, all comments.
Thank you very much. I'm interested for a number of reasons. Why is macropiper not being studied clinically? Macropiper excelsa, the great healer, one of the Maori healers. I'm only 16th Maori, but I've become alert to it and was told to go and have a look when a son had a serious illness. And I started looking at other people's experiences, and if you look at Maori medicine macropiper, you find early writers and medical people made a great deal out of the stories.
I'm completely unfamiliar with what you're referring to, but yes, I'm not, I'd hasten to say I'm not claiming that I'm the first off the taxi rank in these things, but yes, what do I need to say? Thank you. I mean,
Hello, Brian. Thank you. I'm a family doctor, and what I love about family medicine is being able to look after the whole person and hear the stories. So I understand where you're coming from, and I think being able to let the patient know that you believe what they're saying is very important. But I am wondering, with your two hats, what bridges that getting in a more scientific way of looking at things, what evidential bridges or research links these two disciplines? Have there been studies that quantify improvement in an immunological sense with improvement in a psychological sense?
You mean outcomes of using a psychological? Well, I'm not really using a psychological approach in a sense. There are so many dimensions to that question, really. So are you asking for evidence as to whether a whole person approach works or not?
Well, I have been wondering if there have been studies using the two disciplines showing a correlation between healing, and I imagine it would often be a dermatological condition, and improvement in a psychological sense.
Yeah, it depends on what you mean by studies. I guess you're reflecting a desire for quantitation on the basis of statistical studies, as opposed to what is now commonly called singularist approaches, multifactorial singularist approaches, which is now becoming more the focus of research. The realization that when you do statistical studies, you iron out all the story elements, because in fact what you do is you essentialize the condition. So if you take, say, 60, do a study on asthmatics, for instance, how do you define what an asthmatic is? You define them according to either symptomatic wheeze or peak flow rates or whatever it is that is thought to be the best common marker. So they are defined as asthmatics, and then you, in standard care, you treat them with drugs in a double-blind way or whatever. And then you say, well, that's how you should do any kind of study based on that kind of prescription for evidence. But that doesn't work with psychotherapy. You can't blind it. you can't, so you actually have to do outcome studies in which you don't treat one arm with the standard drugs, and then you treat another arm with psychotherapy, and in fact that's very difficult to do, get past funding bodies because they're all stuck on that left arm rather than the right arm. So there's numerous small N studies showing improvement when you include a psychological approach in chronic pelvic pain, urticaria. We've done qualitative studies of patients who have, one study that Karen Lindsay and I did was of patients who had been stuck with severe chronic urticaria and had all the usual medications and entered a whole person approach and got better. So you have to, and that's the standard research frame in psychological studies, where you have to, each person is their own control. So if you're looking for the standard medical kind of study, I don't think we're going to actually get the evidence there. I think we're going to get it by accumulating small N studies. In terms of I'm trying to think about what you're really asking. You've made a dualism, which I create by being me, I suppose, being both a psychotherapist and a doctor. You're saying if you add psychotherapy to medicine, is that going to, or to your general practice, is that going to improve outcomes? Whilst that's what I've done to develop this kind of model, what we encourage people to do is to be general practitioners and expand their view to a whole person approach. Now recently, Galia Harvo-Monteith has just finished her PhD looking at the experience of patients who are chronic illness patients, and not all skin conditions, I have to say, which is, yes, a little bit of a bias in there. 29 interviews of patients who've been stuck in chronic illness and have had a whole person approach and have got better. And what they say about it, this is the kind of evidence that you can get. It's not the evidence you're looking for, but it is the kind of evidence that encourages us to think positively about a whole person approach. What the people say is that I get better not because of what I do, but how they do it. They listen. They treat me as a person. They are a person with me. They're not an expert over there. They're a co-author of the change. So that quite stunning data from patients. That is the venue where healing seems to them to emerge. Now, we found to our... Can I add to that? The way I entered this initially was the urge to be more whole person oriented, but I got excited when I started to see symbolic disorders. Oh, so the story must be connected to the disease because of symbolic representation. Did you pick up the symbolic representation in that story? Yes, okay. I could stray into more symbolic disorders to expand that, but let's stay with that. See, I lost myself then. Where was I going? Yes, what we thought we were doing and what we found amongst our trainees was that if they got hold of the story cleverly and smart and saw the meaning of it, the patient would get better. So we were entering the venue of the whole person through meaning, through symbol, through metaphor. That was how we found ourselves opening up to the whole person. When you go and talk to the patients, they don't see it that way. They see that you've entered the venue and you're kind and you're generous and you listen and you encourage them to make the connection. So actually what you think's happening is not necessarily what's happening. So there's that kind of evidence available. But just to go back to your original question, which is around evidence. I was in Oxford at a medical causation conference just last year, end of last year, and there's a very strong push amongst philosophers, statisticians, public health people, physicians, to start to develop evidence, an evidence base that is based in singularist frameworks rather than these essentializing frameworks that removes a whole lot of data from the study.
Yes, I wasn't meaning just dermatological conditions, because it's a whole gamut. But I take your point, but it's coming back to trying to be patient-centered and giving them power.
I think it's more than that, though. I think patient-centeredness has been around for about 30, 40 years. You can be patient-centered and quite dualistic. So you're very interested in the person and very interested in doing what you can and cooperating and having a good liaison and relationship with them, that you can still hold the body away from subjectivity phenomena. So if you don't seek the story, or because you believe it's part of the causation framework, then in effect you're excluding it from the frame. So I want to make that point. You can be person-centered without being whole-person-centered, and you can be person-centered without being whole-person-centered in a unitive model of the person. So I feel very strongly about that. The moment we divide people up, we start to exclude certain pieces of data.
Brian, this might sound too Cartesian for you, but do you think the resolution of the cancer could have been mediated through the immunological system?
Yes.
So yes, there could be some.
I don't think that's Cartesian.
Pardon?
I don't think that's Cartesian.
It could be verified with markers, couldn't it? Immunological markers.
In a unitive view of the... should I speak with... in a unitive view of persons, it's clear that a person is bodily. It is clear that a person is biological. It is clear that a person is a subject. It is clear that physicality and subjectivity exist together. There will be, and they operate as a whole. They are a unitary whole. And you think I'm going on and on about this, but the issue is there's going to be a physical description for it. If there's a physical description, that does not automatically default to a dualistic position in which therefore there won't be a subjective description. Do you understand what I'm saying? So a physico-materialist view says there is only a physical description. A more unitive physicalist and subjectivist view of the person says there are many dimensions to personhood which include biology and include subjectivity. And those are all going to be potentially relevant and important in both causation and in treatment. As I mentioned very quickly the notion of co-emergence. If you think about the development of a child, when does physicality start? I'm not interrogating anyone here in particular. It's rhetorical. Physicality clearly starts, I presume, at conception. When does subjectivity start? Trick question. And when does spirituality start? I mean, are they add-on factors just due to brain? Or, I mean, those are other issues that come into this. But the reality is that a person is a person from the and develops complexity as time goes on. And subjectivity and physicality are both, well, not both, they are there as dimensional phenomena in the person from the beginning, I believe. So if that's true, if physicality is not just an epiphenomenon, a thing added on, an optional extra, that it's really just the body, if that's true, if I'm right about that, which is how I treat people, then is it reasonable to exclude subjectivity from disease? Because disease arises in a whole person. So just logically and philosophically, it doesn't make sense to exclude those elements from a person's care. And actually, I'm not thinking theoretically most of the time, I'm thinking phenomenologically. Patients love being treated as a whole. That's what they want. And that's what they complain about. They don't get often, particularly in the hospital system. I'm mixing logic and phenomenology there. Did you want to add to that question?
Yeah, I think that's a good start, the pathway I was working out. And I'm not saying that explains it. What I'm saying is that could be the pathway that mediates the response, that's all.
Yeah, well, yeah. I remember being at a physicians' meeting in Christchurch many years ago, and this cardiologist presented a patient who had had this massive heart attack a few weeks before, and it was at one of those Canterbury Auckland super Ranfurly Shield or something. It was one of those super duper battles that Auckland used to be part of, but are not now. Anyway, his daughter-in-law, this man's daughter-in-law, was down from Auckland, and she was sort of supporting Auckland, and he was supporting Canterbury, and Canterbury got beaten. And that what ensued was a terrible row. Thundering row, in the middle of which he had his heart attack. And that was how the physician presented the case. He started there and then went on to show us these wonderful angiograms and how they snatched the clot out of the artery, and phenomenal. And then he said he was sent home on these 3 drugs. And someone said, "So what about the argument?" And he said, "Oh, I was just joking." And then ensued a discussion, well, why wouldn't you consider the argument? And the consensus was, we cannot consider the argument because we don't have a mechanism to think about it. It's not plausible because we cannot imagine a mechanism. That doesn't mean that there won't be a mechanism, but I think that as a first position for people is clinical narcissism. And yet, some of the criteria for science are plausibility. So if your question is, well, what was the mechanism of it? That's I don't know. I think it was relational. I think it was freedom. I think it was likely brain to body regulation of negative mechanisms from those. I think it was everything myself. It was whole person. And to reduce it down to one thing is probably might be convenient if we could measure it, but I still wouldn't believe it. Because I think the mysteries of these things are much larger than simple mechanisms. Right.
Brian, I'm trying to keep up here. What do you mean by subjectivity?
Okay. It's difficult, isn't it? Because if I use the word mind, you immediately think of something specific. If I use emotion, you'll think of something different. If I use spirit, you'll think of something, and everyone will think of something different. If you use subjectivity, you're talking really about the concept of experience.
Oh, cool.
Batteries now.
Hmm?
So now you're a Dalek. just because of your voice through the microphone, nothing more, nothing less. Did you miss that?
I'm lost.
Oh, never mind, don't
What
worry.
was, I think I should have caught something there.
It crackled.
Is it cracking?
Not now, but it was.
I obviously missed it. Sorry, yes. Subjectivity is a broad term for experience. And there are philosophers who argue that experience is a fundamental in the universe. David Chalmers would be an example of that. The capacity for experience is part of nature. And that, so experience is experience. It's subjective. So that's what I mean by subjectivity. And even spiritual experience or relational experience or emotional experience or the experience of thinking, they're all parts of all kind of elements of subjectivity. Physicality is really just a similar term for bodily or concrete reality, aspects of reality. Sorry, I should have explained that.
Excuse me.
Well, I just want to say thank you for sharing Sue's story, your story as well. I guess I'm just curious as to what her journey would have been had she not walked into your office that day. I imagine probably quite different. I was curious, there's something you said right at the start about love and lack of love in healing, and in this Sue's story, the deep shame she experienced. Can you talk a little bit more about that, elaborate on that?
Generally, people don't get unwell because of nice, positive, happy feelings. In all of the stories where we connect stories with illness, it's we're not just picking up meanings, we're picking up felt zones of feeling that may be stuck, anger or fear or guilt or shame, and they are things that are recognised by all of us as things that if they sit there and sit around and within us, they cause us harm, they lower our mood, they make us anxious, and we get triggered from day to day by things that remind us of those or relight those things. So I don't know if that answers your question, but moving, I mean, in her case it's reasonably kind of, conceptually quite simple. Once she realises she did sit on her knee, she could move away from that constraint, that heavy burden. And whereas I think it's much more difficult to move away from a shame where you do feel responsible for something. So I think that's where being loved and accompanied and not shamed is really important. And in respect of that, I worked with a young woman many years ago who, and I won't prolong the storytelling, but who took 2.5 years to tell me, I knew about the sexual abuse, but to tell me more about it. And the real reason was the shame that she carried, because once she had been sexualised by her father, she used to seek her father out as a 9 or 10-year-old. And what she expected from me was more shame, more that I would reject her. I remember when I I heard this eventually. I felt quite tearful actually, and felt absolutely free to say to her, look, it's kind of what I would expect. That if you're sexualized in this way, and this is the only way you can make connection, I could understand how that would happen. And my experience of her was she cartwheeled out of therapy. A wonderful, but it took us 3 years or 2.5 years. Yeah. So I don't want to be simplistic about this. I think I said early on, some things are simple and some things are really hard. But negative emotion, powerful negative emotion that sits there unresolved is a factor in causation, even if it's not the only factor. As are genetic factors and all kinds of environmental factors, infections and so on. Remember, everything is multidimensional and everything is multifactorial. There is not one unifactorial thing in the world, I believe. We make it so. Yeah. I'm happy for more. I'm just getting into my stride.
Michael Bellant introduced the idea of the flesh, which there was some resemblance.
The flesh.
The flesh of understanding.
Oh, the flash of insight, yeah.
Insight. And for a number of years I found it very useful work being in a Bellant group which followed that work that he did. I just wondered whether those groups still exist and what is the value of having a group approach in terms of understanding people in practice.
There are some people in this room I know who are or have been in Bellant groups. They exist in Auckland and are very supportive, I think. Is that right? Yes, I think groups are very important, and particularly from a cultural point of view, because if culture is sort of Western and medical culture, the dominant theme is technology and pharmacology and physical intervention, there isn't a lot of room for these other things. And secondly, you can be very alone in doing these things. So having people that will support one another in doing it and keep a check on excesses in the area, or keep balance in this area, I think is very important. And that's the MindBody community days that I think Nicola referred to at the beginning is an example of that. We do group supervision in various forms. So no, I think groups are important. There's still a couple down the back there.
Do you think there is always or usually a psychological cause or factor in unresolved chronic illness? Or do you think that there are occasions that there isn't a significant factor in that space and really is a physical ailment that is unresolved because there isn't found a solution?
Yeah. I don't tend to think about it as always or not, because that's another kind of...
Or usually.
Yeah, or usually. I always look, is more my approach. And particularly, and looking is not so much inspecting, but inviting the person or inviting myself into the person's space to talk about what else might be influencing it. So I tend to think about influences. I mean, if you want me to theorise, I'm not saying you do want me to theorise, but if I respond to it from a theoretical perspective, I would say it's pretty difficult to imagine an illness where physicality and subjectivity such an integral part of being a person that in some way or other, treating the elements of subjectivity is not important. Now, clearly, if you fall out of an aircraft or jump out of an aircraft, you don't ask for a story as you pick them up from the ground and put them in an ambulance. Clearly, there are priorities in all of these things, and so that's true of many conditions that are people that are with acute conditions admitted to hospital. Rescuing the physiology is the most important thing to do at that point, though generously and tenderly tending to the conscious patient who's suffering is really crucial as well. But in terms of causative factors, I think the answer probably is always there's something there, but whether it's worth approaching becomes an issue of pragmatics, an issue of patient choice, because it becomes an issue of side effects of drugs and treatments, or failure of drugs and treatments. It becomes an issue of economics. Who should I apply the story approach to when I've got 10 people in a clinic and with a little bit of medication this person will find equilibration for their pain, and I can get on and provide care for someone who will not get such equilibration. So all the time there's a kind of triage going on.
I mean, I guess I'm considering the chronic unresolved chronic illness, I guess,
yes,
is where I'm coming from.
And it's most applicable there. So from an economic perspective, clearly that's the area of greatest importance, I think. And we're not just talking economics from the perspective of the person. This whole thing is full of nuances that have to be acknowledged and encountered as you go along. Any one over there?
Thank you. I really appreciated your openness to the mystery, because as you were open and you were saying to see, I don't know where we're going, you invited her to travel with you on her river and alongside your river, and that enabled her to discover her own healing truth. It's not the professional giving that to the patient, but it's the patient's eyes opening and discovering it. And that happens when they're respected and they're able to travel and travel through the mystery with you. So thank you.
Thank you.
I wholeheartedly agree with your unitary approach to health, but I just am struggling to see the connect between A and B, because the connect between connection itself and healing, because from what I've observed in people around me and moreover in my own life, is of course there's like a direct cause and effect between something like a root cause from way back, and then and its manifestation, and then more current triggers that set you up. I see like an absolute connection, of course, like it's undeniable, but I think acknowledgement alone is not enough. I think you can 100% see it and say, I can see how this has happened and I can see what issues have brought this on, but simply acknowledging it does not create healing. I think some people just live with that fact and they go through life going, oh, because this happened to me when I was younger, this has happened to me now, and that's it. You know, like, I mean, so what I mean is, can you connect those dots between A and B? Thank you.
I think there's a continuum, really. A lot of in our study of chronic urticaria, or my audit of chronic urticaria many years ago, I pulled 22 patients out of my database that I had labelled in the database as having chronic urticaria based on psychological or story elements, or at least they were participating in it and had responded to them in that way. So that they were selected because they were in the database, and the other selection criterion was they hadn't been seen for 6 months. So I wanted to know what had happened to them. And I devised a little questionnaire and spoke to all of them. And 13 out of the 22 had the same story. They got better once they knew there was a connection. And they'd only ever had one assessment with me, or one assessment plus a follow-up. And I asked them, what do they think made it possible for them to get better? Firstly, they said, once you said there could be a connection. Secondly, I knew what to do. I talked to my husband. Insisted that he didn't go pig hunting every weekend, leaving me with the 2 small children. I knew what to do. And some of them would said, occasionally I get it back, but I know what to do. So what I'm saying there is that just being the kind of clinician who's willing to make the connection and legitimise and validate a non-dualistic approach will help some patients. And maybe we could help a whole lot of patients with minor conditions that way, just by making that connection. And I'm sure GPs do a lot of that kind of work, connecting stress with feeling unwell and so on. The other 9 had gone into what we would call mind-body psychotherapy. 7 of them had got well and 2 had not. And the 7 that got well basically said the same thing, but they all had taken a variable amount of time to work on their feelings. They weren't in contact with their feelings. They weren't able to make the connections in the same way, and they needed help in that. So, and then there are patients, and I've had some patients in Auckland over the last few years who've taken 2 or 3 years to gradually get in touch with feelings and experiences that were highly traumatic. So those connections were not easily made. They were made in the intensity of a caring and generous relationship. So you're quite right. For many people, acknowledgement, cognitive acknowledgement, is not going to be enough. But for some it will be. So in practice, what I do with everyone is I tell them that I'm interested in them as a whole. I will be asking them questions about both the normative physical things and also their stories, and are they okay with that? And invariably patients, I mean invariably these days, patients say, oh, that's good, or oh, I'm okay with that, or that sounds good. It happens every time. I do that at the beginning of a consultation with a new patient. And that gives me permission to ask if I feel that that's appropriate. So I'm making connections right from the beginning. Even introducing myself and saying I'm interested in those things is making a connection. But I'm well aware that there are many of our patients who go on to have formal psychotherapy and who have a much more elaborate and difficult journey before they can be helped, or if they can be helped. So I don't know, does that answer your question? Okay.
There's two other questions that were there before, and I think that might draw things to a close. I think there was one here, Peter, or John, was it? Or,
Hi, Brian. Peter Bell.
Okay.
Brian, just asking a few comments really on, as you sort of have embarked on this adventure of engaging with the whole person, you mentioned that it's a sort of there was a mutuality there, it affected you and it changed you. And I'm just wondering, can you make any comments on how it changed your spirituality, or your spirituality?
Yes, I was brought up in a very kind of dogmatic, essentially cognitive spiritual frame, in which the most important thing was a factual truth in abstract terms. So it was doctrine, it was belief, it was who was right and who was wrong. And so I started to see in this kind of work that, yes, you're absolutely right. I see exactly what you're saying. I started to see, whether it was in psychotherapy or whether it was in reflecting on the domineering nature of rigid systems, whether it be religious doctrine or biomedicine, that there is truth to be found, important dimensions of reality to be found in all sorts of corners, all sorts of places. So it started to change me in terms of looking at things in terms of in what way is this thing that I'm hearing right? In what way is it helpful? So instead of being sort of colonized by yet another system, I became an integrator of, I wouldn't say bits and pieces, but influences, things that really made a contribution to the care of patients, to my experience of the care of patients, to my experience of subjective reality. I think it then, my spirituality started to shift to an experiential kind of emphasis rather than a hard-nosed, factual emphasis, though still acknowledging that there are facts and there are truths and there are things that are really important and remain right through the ages and so on. I think the other thing that happened was that I realised, and this is the short version, I realised that gradually that it wasn't my smart insights that made the difference, though insight's really helpful, and being attentive and hearing and accurate is crucial. But being willing to be in the space with people relationally rather than algorithmically is very important. And so I think my spirituality sort of became more relational, and in the end you end up skidding towards the position which has been held for centuries, that you can't trump love. You can swamp it, but you can't trump it. And so that's very important to me. Of course, it's very testing at times, but so I guess my spirituality is, for want of a better term, a relational spirituality. I see in human functioning an intense need and desire for and reaction to relationship. I see what happens to people who are traumatized in relationship, who get illness. We see in the child longitudinal studies, children that have been abused physically, sexually and emotionally, by the time they're in the 4th decade, they have a much higher prevalence of inflammatory disorders than the population that are not abused. We see it everywhere. We know it innately, that love and relational dynamics are crucial to our functioning. So I guess I'm much more focused on a spirituality that honours that, wherever it comes from, as opposed to a spirituality that argues for a position on the grand scheme of things. I'm intensely sceptical of theories of everything, having had a few of my own.
Okay, one last question. You've got time for that.
Actually, I think it was once you answered and you asked the last question. Just curious, what you have steered away from using the word God. This is a lecture, understand God and TV.
Yeah, I deliberately did that tonight because I wanted to convey spiritual activity as something embodied, something in the world, something that we enact, something that we is a living, breathing thing, rather than a term, an abstract term which triggers a whole lot of reactivities. I would invite you to see from what I've said and what I did whether I have a concept of God or not. I believe there's a deeply spiritual aspect to existence, and that how much further shall I go? In a way, you can probably see in my value system that there's a lot that comes from my Christian spirituality, which I hugely value, even though I've tried to toss out the dogmatic element or the hard-edged element. But I think Christian spirituality has to be incarnate. It has to be embodied. I don't have much time for a spirituality that is theoretical and is conceptual but is not embodied. And that's what I've sort of tried to convey tonight.
Can I make a comment, please, just on that point?
Is it a nanoset?
Yeah.
Because that's all I've got time.
Brian, when you talked about your approach in engaging with people and your openness to just this entering the space with this other human being, what occurred to me from listening to you is that was the experience of communion.
Sure.
Yeah.
Mm-hmm.
Well, thank you very much. It's, I have to say, from my own perspective, you've got me wondering about the scientific method and the way we isolate variables and indeed how we, in our set of results, we remove anomalies and outliers. But that's something that I can talk to your brother about as well. So,
It was marvellous and very true, and I won't say too much for your needs today, so please do accept this one.
Thank you. Thank you very much.